So my name is Eryn Dow. I'm a medical oncologist and a clinical cancer geneticist, and I work at the Peter MacCallum with Mike in the Parkville Familial Cancer Center, but also in the oncology service at the Peter MacCallum. And I'm going to sort of step off from where Mike stopped today. So he talked a lot about risk assessment, the triaging, what happens to a patient when they're referred to our service. And I'm going to talk more about how we manage patients that we know have a gene mutation and what the cancer risks associated with the gene mutation, each different type of gene mutation are. The brief was to talk about breast and colorectal cancer, but you can't really talk about breast cancer without talking about ovarian cancer, and you can't really talk about bowel cancer without talking about endometrial cancer. So there's a few other important cancers that will get a mention along the way. And at the end, I just wanted to finish up with some of the rarer things, but that are still really important that they get sent to an FCC. So to really help flag, I guess, some red flags for your mind, who we really want to see. So Mike alluded to this a lot. We have this problem in genetics where there's a balance that has to be struck between what a person can know and what a person wants to know. And this is a really tricky balance, and this is something that the genetic counselors are excellent at teasing out individually with people. And it is, I would argue, not only person-specific, but also disease-specific. And really, all you can know from a genetic test is risk. So gone are the days of Gattaca. Hopefully this room is old enough to get that reference. Our genes aren't our destiny. Our genes provide a risk, but that risk interacts with the environment, lifestyle factors, and other genetic factors. So when we tell someone they have a genetic mutation, we're not telling them they will get cancer, but that's often how it's interpreted. So it's really an important part of our service to talk to patients and to clarify with them that what we're talking about is risk. And that risk is variable because of variable penetrance, lifestyle factors, polygenic risk. Some people want to know this. They find it really empowering. It gives them back a sense of control. They feel like they can manage a risk. Some people don't want to know this. They find it very overwhelming. They have more of a fatalistic view about it. So this is really what an appointment at our service is about, is teasing this out. Might start with breast cancer because it is the most common cancer in Australia. This is data from Australia from last year, 2018, and over 18,000 people were diagnosed with breast cancer in Australia last year. So it is the most common cancer when you put men and women together. You can see that the incidence is increasing. I don't know does this mouse show up? Yeah. The incidence is increasing, and I've only included the data for women, but the incidence is also increasing in men. But the mortality is decreasing thanks to improvements in treatment. And the average 5-year survival now for a woman diagnosed with breast cancer is 91%. So treatment really has come a long way. And if identified early, this is a very treatable disease. Breast cancer has a lot of risk factors, but the most predominant risk factor is age. The older a woman gets, the higher her chances of developing breast cancer. There are, of course, hormonal factors, and it really has to do with cumulative lifetime exposure to estrogen. So women who had a very early menarche or go through a very late menopause have a higher lifetime exposure to estrogen and therefore a higher risk. And women who had a very late age at first pregnancy or who didn't have children will have a higher risk. Of course, the use of exogenous estrogens can also increase that risk, so the oral contraceptive pill, hormone replacement therapy, but to a lesser degree actually than was historically thought. And we'll talk a little bit about that later on. There are lifestyle factors that play into it. Obesity and lack of exercise are quite well demonstrated now in big trials. And breast cancer is actually significantly associated with alcohol intake. So more than 2 to 3 standard glasses of alcohol a week significantly increases the risk of breast cancer. And intriguingly, it's one of the few cancers not associated with smoking. Women who have high breast density or who have had pre-malignant lesions have a higher risk of breast cancer. And then, of course, the family history plays into it. And this could be high-risk single gene mutations like BRCA1 and 2, as Mike's mentioned, or polygenic risk, which Mike also alluded to. This is a very similar picture to what Mike showed you, and we prepared it independently, so I guess it just tells you that this is important. Most breast cancer is sporadic. So most women who develop breast cancer fall out here in the big part of the pie. But there are a proportion of women who will have an inherited basis to their cancer, but only about half of those women will have an identifiable hereditary cause, like a BRCA1 or BRCA2 mutation. A significant proportion of those women will have polygenic risk or other genetic factors, which at this stage we can't clinically test for. So breast cancer can be familial, but still not have an identifiable gene. And that can be really challenging for patients. So the goal really is to identify families who have this high-risk gene mutation, and we use a lot of different factors to do that, as Mike has explained. I thought this was a helpful graph to sneak in, and I'm sorry it doesn't project very well, but if you look up here at this tail of the graph, so in very uncommon things, so things with a very low allele frequency in the population, this is where we find BRCA1, BRCA2, TP53, these high-risk gene mutations. So having one of these gene mutations infers a very high relative risk of breast cancer, but they're very uncommon. And as we move down the graph, we have some moderate risk genes here in the middle, and down towards this end, we have these SNPs and polygenic risk, these subtle changes that are very common in the population that might increase your relative risk by 1.1 or 1.2. And these are the things down here that we can't yet test for. It's coming, probably sort of 5 to 10 years off clinical practice. So although I've been calling these breast cancer genes, I just wanted to flag that they should be considered more general cancer genes because they increase the risk of a lot of other types of cancer. So BRCA1 and 2 are also significantly associated with ovarian cancer, an increased risk of prostate cancer in men, and an increased risk of pancreatic cancer. Some of these other genes that are considered breast cancer genes, like PALB2 and ATM, probably also increase the risk of pancreatic cancer, although the numbers are hard to quantify. PTEN and STK11 often get mentioned as breast cancer genes, but really I think of these as general cancer genes. So PTEN causing Cowden syndrome has a risk of endometrial cancer, bowel cancer, renal cancer. STK11, Peutz-Jeghers, increases the risk of breast cancer, but also bowel cancer, endometrial cancer, pancreatic cancer. So I think when we approach patients with these types of gene mutations, we've got to think sort of more broadly across the scope of cancers, not just about breast cancer. So Mike's already talked a little bit about Boadicea, which is a quantitative algorithm that we use to predict risk. There are a number of these available, and we use these in our clinic to assess the chance that a woman has an underlying, predominantly BRCA1 or BRCA2 mutation. They've been compared head to head, and in that study, Boadicea does come out slightly ahead of the others as the most effective and accurate tool for assessing risk. And so that's what we use in our clinic. But it is quite an involved computer algorithm, and it's not something that we would expect other people to use. Particularly, I don't think it's something that you would have time in your practice to get all that information into. The nice thing about Boadicea is that not only does it give us a risk of an underlying mutation in a family, but it also gives us a lifetime risk of cancer for other members of that family. So it's actually a pretty useful tool. But one that's slightly more user-friendly is called the Manchester score, and it is sort of a traditional add up the scores in the family, and if you get over 15, then they're potentially at high risk. And I've put the link there, but if you Google Manchester score, it'll come up, and that's much more user-friendly and can be done in a couple minutes in clinic with a patient. Not quite as accurate, but gives you a good idea. And the reason we do this, which Mike again has already alluded to, is because of the recently introduced Medicare rebate for BRCA testing. So the rebate states that the test can only be ordered by a specialist consultant physician and can only be ordered if a quantitative algorithm calculates greater than a 10% chance of an underlying genetic mutation in a woman who is affected by cancer. So we're really limited in the tests that we can get funded through Medicare. And we use these algorithms to try and determine who's eligible. As Mike said, we do have sort of a pot of money in our department for other women who don't meet these stringent criteria, but who we think still really need a test. And usually those are very specific circumstances. I wanted to just mention iPrevent while I was talking about quantitative algorithms. I don't know if any of you have come across this. This is a project to come out of Peter Mac that's been headed up by Professor Kelly Phillips, who's one of the breast medical oncologists there. It's an online web-based platform that has been designed to be used by patients with some help from a medical practitioner to determine the risk of developing breast cancer. And it's quite user-friendly. The patients just go to the website, they enter their personal history, so their reproductive details, details about breast biopsies or pre-malignant lesions they've had in the past, and a little bit of information about family history. And the program itself uses either Boadicea or IBIS, which is one of the other risk prediction programs, depending on the information it collects. So if a woman has a history of pre-malignant lesions, it defers to IBIS because that's a better algorithm in that setting. And if a woman just has a family history, it uses Boadicea. So that's all happening behind the scenes. No one, the women who are doing it don't know that's going on. What they get is a screen that looks a bit like this. So it's a quantitative assessment of their risk of developing breast cancer in a pictorial form compared to the population risk of developing breast cancer. And if they click through that, it actually tells them about their options to manage that risk. So this is a pretty easy to use platform. It does take about 15 or 20 minutes for a woman to put in all of her information. So it's probably not something to have patients do in your rooms, but they could perhaps, if you have an iPad, do it in the waiting room while they're waiting, or you could give them the link and send them home to do it and come back with the information. It groups women into 3 categories, which are the same risk categories that we use when we assess women's risk of breast cancer. So there's population risk or low risk, which is anyone with a lifetime risk less than 18%, and they get population-based breast screening through Breast Screen Victoria, second yearly mammograms from 50. The women who fall into the moderate risk category, so they have a lifetime risk of breast cancer between 18 and 29%, and we recommend that they have increased screening, including annual mammograms between 40 and 49, and second yearly mammograms over the age of 50, and that's because of breast density and the sensitivity of mammograms at different ages. And we also recommend that they consider chemoprophylaxis or risk-reducing medications, and I'll talk more about that in a few minutes. For women who are at high risk, so women who have a lifetime risk of 30% or higher, and these are not necessarily BRCA carriers, but they could be, we do recommend that they have MRI-based breast screening from 25 years old. Now, those MRIs, in order to be Medicare rebatable, can only be ordered by a breast surgeon. So functionally, what needs to happen is they need to be referred to a specialist for their screening. And from 50, they usually swap from MRI back to mammogram. We'd also consider risk-reducing medication, and some women would consider preventative surgery in this situation. So these are the most recent figures we have for the lifetime risk of breast and ovarian cancer in BRCA1 and 2 mutation carriers. So the blue line is BRCA1 and the yellow line is BRCA2. The first graph here refers to breast cancer. So if you look at a cumulative risk to age 80, these women are at a 70 to 75% chance of developing breast cancer in their lifetime. So it is a high risk, but you can see that that risk is age dependent. So under the age of 25, the risk is negligible. And so really that's why we recommend that women start their screening there. And on this side, we've got the risks for ovarian cancer. You can see BRCA1 has a much higher lifetime risk of ovarian cancer, approaching 40%, compared to BRCA2, where the risk is under 20%. And we'll talk more about managing ovarian cancer risk shortly. But you can see that if our cutoff for high risk is 30% lifetime risk, BRCA carriers are reaching that by the age of 40. Their lifetime risk is actually closer to double that. So there are a lot of women who will be high risk, but not BRCA carriers. So how do we manage this risk? We've got sort of a 3-pronged approach, and it goes up sort of in increasing levels of invasiveness in terms of managing the risk. First of all, we recommend that all women are referred to a high-risk clinic, and most of the major oncology hospitals have a high-risk clinic that's run in combination with the surgeons and the oncologists and the genetics team. So it's a multidisciplinary clinic where patient can have access to all of those services. The first thing, and the only thing that we absolutely recommend for these patients, is increased breast cancer screening, which is, as I said, annual MRI plus or minus ultrasound or mammogram at the surgeon's discretion from the age of 25. A 6-monthly clinical exam, so usually one of those is done annually by the breast surgeon, and then the intervening 6-monthly exam we try and get the family doctors involved in. So that's sort of the only thing that we'd tell women, we really need you to do this. Now the goal of the screening is to pick up cancers early, but it of course does not prevent cancer. So if women want to do something more active to reduce the risk of cancer, we talk to them about chemoprophylaxis or risk-reducing medications. which I have a slide on shortly. If women want to do everything that they possibly can to reduce the risk of developing breast cancer, then they can consider having prophylactic bilateral mastectomies. Currently, for women with a BRCA mutation, that is covered by Medicare, including the reconstruction. It's a long process. It involves meeting with a breast surgeon, meeting with a plastic surgeon, and meeting with a psychiatrist, because these surgeries have significant impacts on a woman's self-image and her sexual health down the line. So we take it very seriously, and it's a very involved process for a woman to get to prophylactic mastectomy. And of course, every woman should practice good breast self-awareness, which we're now using instead of self-exam. So risk-reducing medications, what are they and how do we use them? These are essentially hormone-blocking medications. They're all tablet-based. We recommend that women take them daily for 5 years, and this is based on large randomized control data, which confirms a 30 to 60% reduction in the lifetime risk of breast cancer for women who took these medications for 5 years. So even after they stop, we now have data out to 20 years after cessation of these medications, and their risk is still half what the women who were on placebo was. So it does seem to have a long-term benefit. The most common one of these medications is tamoxifen, which is actually the only one that's PBS listed for this indication. It's a selective estrogen receptor modulator, or a SERM. So essentially it blocks the estrogen receptor in the breast tissue. So it can be used in pre or post-menopausal women. It does have side effects, usually menopausal type symptoms, hot flushes, that sort of thing. But there is a slight increase in the risk of clots, so it's contraindicated in anybody who's had a PE in the past. That risk is similar to the oral contraceptive pill, about 1 in 100. It also increases the risk of endometrial cancer. It's about 1 in 1,000, so it's uncommon, but it is an increased risk. The other group that of medications that have been used in this setting are the aromatase inhibitors, so anastrozole and exemestane. They are not PBS listed, but there is pretty good data that they work in a similar way. They can only be given to post-menopausal women because they work by reducing estrogen production outside the ovary, so predominantly in the fat via aromatase. And so they do not affect ovarian estrogen production, and so they're not effective in premenopausal women. And tamoxifen is the only one on the PBS. So this is the randomized trial data, and I just wanted to give you some pictures to prove that there is some evidence behind what we're doing. So the first two here are the cumulative incidence of breast cancer in the forest plot for tamoxifen versus placebo. And you can see placebo is the blue one and tamoxifen is the red one on this graph. So for women who were followed for 20 years after they took either tamoxifen or placebo, you can see the placebo group, the incidence of breast cancer is about 12%, and the group that took tamoxifen, it's dropped to about 7%. So there's a significant reduction. And on the forest plot, you can see that all of these values are following below 1 for their hazard ratio, so they're favoring tamoxifen. The only exception where they're crossing the sort of leaning this way or crossing 1 are women who used hormone replacement postmenopausally, and women who developed DCIS or pre-cancer. It doesn't seem to prevent that as well. This is the data from the IBIS-2 trial, which used anastrozole, so used an aromatase inhibitor compared to placebo. And unfortunately, they swapped the colors, which is a bit annoying. So in this one, placebo's red and anastrozole's blue. But again, you can see the relative risk reduction in the incidence of breast cancer. And most of these values falling below 1 for their hazard ratio, so favoring the use of anastrozole. And this one here that's crossing 1 is the development of ER-negative cancers, or estrogen receptor-negative cancers. And I guess that sort of makes sense, that blocking estrogen isn't going to stop you from developing an estrogen receptor-negative cancer. One of the questions we get a lot is, what about women who are at a high risk of breast cancer and the use of hormone-based medicine? So can a woman with a BRCA mutation take the pill? The evidence is sparse, but there is no evidence at this point to recommend against the oral contraceptive pill for family planning in women with a BRCA mutation. We know that it may slightly increase their risk of breast cancer while they're on the pill, but there doesn't seem to be a long-term increase in the risk of breast cancer. And actually, the increase in the risk of breast cancer in magnitude is quite small, and there's a much larger magnitude reduction in the risk of ovarian cancer for these women who take the pill. So we'd say on the balance, which of course needs to be discussed with the patient, there's no evidence to recommend against the use of the oral contraceptive pill in these women. There's even less data on other hormone-based methods of birth control like implanons and Mirenas. There's a relatively recently published article that demonstrates that women who have multiple Mirenas may have a significantly increased risk of breast cancer, which is concerning because we thought the systemic absorption of that would be quite low. It's very new data, but I guess we tend to lean away from unopposed progesterones when we're talking about birth control. So we think it's probably safer to use a combination estrogen-progesterone than to use an unopposed progesterone method of birth control. And what about hormone replacement therapy? There's fairly good evidence now that for women who had a BSO, or a bilateral salpingo-oophorectomy, the short-term use of hormone replacement therapy around that surgical menopause is safe. So we'd say for less than 2 to 3 years, there's no significant increase in their risks of cancer long-term. But women should not be on hormone replacement therapy past the natural age of menopause. So by 51, 52, women should be off hormone replacement therapy. And if a woman's had a hysterectomy, consider using estrogen-only preparations. You can't use unopposed estrogens in women who still have a uterus because of the risk of endometrial cancer. So that's probably a question we get most commonly from general practitioners. And there isn't a lot of data, but that's what we've got to work on. Now we can't talk about BRCA1 and 2 without talking about ovarian cancer, so I'm going to take a slight side step. If we think about ovarian cancer, again, the vast majority is sporadic, but a small piece of this pie is due to high-risk single genes like BRCA1 and BRCA2. And actually, if we look at all of the women who develop epithelial ovarian cancer, the risk of finding a BRCA mutation is between 13 and 22% in that cohort. And for that reason, we accept referral in the FCC of any woman under the age of 70 with high-grade serous ovarian cancer. And that's an automatic indication for us to do a BRCA test. It really is the high-grade serous ovarian cancers that seem to have this underlying BRCA1 and 2 mutations. In the other types of high-grade non-mucinous or high-grade epithelial ovarian cancer, like endometrioid and clear cell, it's much less common. So it really is this high-grade serous group that we're targeting. If we think about how we manage the risk of ovarian cancer, if a woman's been found to have a germline BRCA1 or 2 mutation, and we think about that same three-pronged approach, there's been some good data now come out of large randomized control trials that there is no benefit and there is actually possible harm from the use of annual pelvic ultrasound and CE125 screening. So we have to recommend against it because the published evidence at the moment says that actually these women have worse outcomes who are having screening than the women who are not. So they did quite large studies in the UK and followed women regularly, either standard of care, only investigated when they had symptoms, or annual ultrasound and CA125 monitoring. The women who had annual monitoring had a higher rate of surgery, but no higher rate of ovarian cancer prevention. They weren't diagnosed any earlier, so there was no stage migration to pick them up earlier. And there was a higher rate of post-op complications that actually resulted in a higher mortality in the group that was having screening than in the group that was not having screening. So I think we've got pretty good evidence that this doesn't work. And so there's no role for screening in ovarian cancer, but of course if a woman has symptoms, investigate those symptoms. And the symptoms are very non-specific: bloating, abdominal pain, change in bowel habits, weight loss. There is good evidence that taking the oral contraceptive pill reduces your risk of ovarian cancer, but unfortunately this is not a TGA approved indication for the oral contraceptive pill, and it's of course not on the PBS for that reason. So we can't actually recommend it because it's not a TGA approved indication, but it does reduce the risk if a woman's taking it for family planning reasons. And as I said, it may slightly increase the risk of breast cancer. So what does that leave us with? It leaves us with surgery. And this is what we recommend to all of our families, that women have preventative bilateral salpingo-oophorectomies. And the age at which that's done depends on what gene it is, but generally premenopausal. Even after a bilateral salpingo-oophorectomy, you still have a residual risk of primary peritoneal cancer of about 1.3%. So it's not a guarantee that this woman will not develop ovarian cancer, because primary peritoneal is a type of ovarian cancer, but it does significantly reduce the risk, and it's the best thing we've got at this point. Again, just a little bit of data to prove that it does work. Now, these forest plots are really frustrating because the dashed line is the assumed effect line, it's not 1. So I've just added where the relative risk of 1 is to make it a little bit interpretable. So you can see this first plot here is ovarian cancer risk reduction in BRCA1 and 2 carriers, and the relative risk of 1 falls way out here. So there is a significant benefit for these women having a premenopausal BSO. The second graph here, B, is BRCA1 and 2 carriers and their risk of breast cancer following premenopausal BSO. So you can see that if a woman has her tubes and ovaries removed premenopausally, it actually reduces her risk of developing breast cancer as well. And that's because of the effect on the hormones that surgery has. And C and D are just BRCA1 and 2 respectively as subgroups. So you can see that it does work, it does prevent ovarian cancer. And this is the same graph that I showed you earlier about the incidence, and really just to talk a bit about the age at which we do it. So for BRCA1 carriers, we recommend they have their tubes and ovaries out at 40. For BRCA2 carriers, you can see the risk starts later in life, and so we recommend that they push that surgery back to 45. And that's to manage the side effects of early menopause with the cancer risk reduction. So you really have to strike that balance. We don't want to cause a lot of very premature menopause because of the risks of ischemic heart disease and osteoporosis that are associated with it. All right, breast and ovarian cancer done. Moving on. Bowel cancer, third most common cancer in Australia with about 16,500 cases diagnosed last year. Again, the incidence is relatively stable, but the mortality is improving as treatments improve. This is actually UK data, but it is the same in Australia. I just couldn't get numbers for Australia. And so if we think about all the people that will be diagnosed with bowel cancer in Australia, only a small proportion of those will have a family history, and of those people with a family history, an even smaller proportion will have a single gene explanation. So similar to breast cancer, and similar environmental and lifestyle risk factors. But bowel cancer is associated with smoking, whereas breast cancer, there doesn't seem to be a smoking association. This is a really wonderful paper that was published last year by a group out of the University of Melbourne, headed up by Mark Jenkins, about bowel cancer risks based on family history and the screening recommendations. So these are the current Australian screening recommendations, and they did just change about 4 months ago. So again, worth having a look. These are for families where they do not have a genetic mutation. So this is not Lynch, this is not FAP. These are all other comers. And it gives you a way to calculate their risk based on their family history, and it very clearly outlines the new screening guidelines based on that risk category. So I know you probably can't read it, and in the interest of time, I'm not going to read it to you, but you'll have access to these slides, so you'll be able to look at it. Bowel cancer genetics, the pie graph looks very similar to breast and ovarian cancer. The vast majority is sporadic. And then the big players in the hereditary space are Lynch syndrome, FAP, and then a smattering of other rare things. Bowel cancer, as we know, develops via the adenoma-carcinoma pathway. So these people do develop adenomas or polyps prior to developing carcinomas. And that rings true even in Lynch syndrome, which I know we call not polyposis hereditary bowel cancer, but they do actually develop a polyp before they develop the cancer. It's just that they don't develop hundreds of polyps. And in Lynch syndrome, we think that this process from sort of hyperplastic endothelium to cancer is very accelerated. So where in a normal person, you might have many years from adenoma to carcinoma, in someone with Lynch syndrome, and because of the genetic predisposition, you may have a year or 2 years from adenoma to carcinoma. So it's a much faster process. And that's, of course, because they're born with their first hit, their germline hit, and then when they develop a second hit, if we sort of go back to very basic genetics, Knudsen, back in the 1970s, you get a really rapid progression down that pathway. So they're sort of primed because of their germline mutation. Lynch syndrome is the major condition in this space. It's caused by heterozygous mutations in one of 4 Lynch syndrome genes, MLH1, MSH2, MSH6, and PMS2, or deletions of EpCAM. And that's because EpCAM is immediately upstream of MSH2 in the genome, And so if you have a deletion at the end of EpCAM, it affects the expression of MSH2. So it's sort of sneaking its way into the Lynch syndrome group of genes. Although these are traditionally thought of as bowel cancer genes, they also increase the risk of endometrial, ovarian, gastric, and urothelial cancers. And we identify these families. We don't have a fancy quantitative algorithm for these families, and we use the Amsterdam 2 criteria. So 3 or more individuals in a family with a Lynch syndrome associated cancer over at least 2 generations, at least one of whom was diagnosed under the age of 50. And of course, FAP should be excluded if it's a bowel cancer family. And we do try and confirm the tumors through CCV verification. And we do recommend that those tumors have pre-genetic testing. So the most common pre-genetic test that's done on a tumor is mismatch repair immunohistochemistry. This looks for those 4 Lynch syndrome proteins and their expression in the tumor. And if one of those proteins is absent or is lost in the tumor, then that's an abnormal result and raises the suspicion of Lynch syndrome. But it's not a confirmatory test, it's a screening test. That loss of expression of the protein could be because of somatic changes in the tumor and have nothing to do with their germline. So they could have abnormal IHC and not have Lynch syndrome. But we see anyone with abnormal IHC in the familial cancer clinic to try and nut that out. MSI, or microsatellite instability, is another test for pre-screening or pre-genetic test for Lynch syndrome, but it looks at the functional outcome of having a mismatch repair deficiency. So it tells us, is this tumor acquiring somatic mutations like a tumor that is mismatch repair deficient? So these tumors develop thousands of little spelling mistakes because they've lost that ability to do mismatch repair in their DNA. So that's what MSI looks for. It doesn't tell us it's Lynch syndrome. It doesn't tell us what the mechanism of those mutations is. It just tells us this is a tumor with a really high mutational burden. This is a tumor that has a really unstable DNA repair pathway. Again, we will see those patients and we will nut out what is causing the MSI in those tumors. The most common reason that we find MSI or abnormal IHC that is not Lynch syndrome is due to promoter methylation in the tumor. So the MLH1 gene's promoter gets methylated in many tumors, particularly in tumors in older patients, and this methylation silences the gene. So it sort of creates a pseudo-Lynch syndrome somatically in the tumor that has nothing to do with that patient's germline, the genes that they were born with. So it's not Lynch syndrome, but it mimics Lynch syndrome in the tumor. So this can get really nuanced and really tricky, and that's why we are happy to take referrals for patients with any abnormal MMR-IHC or any abnormal MSI, and then we'll try and nut out exactly what's causing that and whether it's Lynch syndrome or not. But we would consider these patients at least suspicious of Lynch syndrome until we have more information. What are the cancer risks associated with Lynch syndrome? Again, I'm not going to read them all out to you. This table is really just to give you an idea that it's not just bowel cancer. And in some of these genes, like MSH2 and MSH6, the risk of endometrial cancer is actually higher than the risk of bowel cancer. There's also an increased risk, as I mentioned, of gastric, ovarian, urothelial, and even small bowel cancer. And I guess the other interesting thing is that the 4 Lynch syndrome genes are not created equal. MLH1 and MSH2 have higher penetrance, have higher cancer risks than MSH2 and PMS2. The risk management for Lynch syndrome involves multiple steps. It doesn't fit quite nicely into my 3-pronged approach, but that's because we have multiple cancers to think about. So for bowel cancer, these people should have annual colonoscopy-based screening from either 25 or 30, depending on which gene is involved. And if they are developing multiple cancers or multiple polyps, they may end up having a subtotal or a total colectomy to manage that risk. But that's a decision that the surgeons will make based on their colonoscopy results. And we would consider chemoprophylaxis with low-dose aspirin in these people, and I'll talk more about that in a moment. To manage the risk of endometrial cancer, there is no surveillance, and the recommendation is that women have a hysterectomy on completion of childbearing or from 40 years of age, whichever is first. And to manage ovarian cancer, again, same as for BRCA, we recommend a bilateral salpingo oophorectomy premenopausally based on the penetrance by each gene. In some families where there's a history of gastric cancer, we would do second yearly endoscopies, but there's a paucity of evidence that that actually makes a big difference. And there is no recommended screening for urothelial cancers, but we do recommend that patients are aware of any blood in their urine and seek investigation early if they notice any hematuria. This is a slide taken from the CAP2 study, which was a randomized placebo-controlled trial of aspirin in people with Lynch syndrome. And in this graph, the placebo is the blue line and the people who took aspirin is the red line. And this is the incidence of a Lynch syndrome-associated bowel cancer. So you can see there is a reduction in risk for people who took aspirin daily in their incidence of bowel cancer. Now this study was done, you probably can't read it, at 600 milligrams a day of aspirin, which is a huge dose. There are follow-ups to this, CAP3 and even CAP4 now I think, are ongoing, recruiting patients to try and find the right dose. There was a reasonable amount of bleeding and reflux and peptic ulcer disease in this cohort at that dose. And so that's why at this point we're recommending low dose aspirin, so 100 to 300 milligrams a day as prevention. But hopefully when we get the results of CAP3 and CAP4, we'll be able to be more definitive about what the recommended dose is.
How does it look?
That is a good question. And we don't completely know the answer to how it works. We think that it has to do with reducing the local microinflammation in the bowel, because we know that chronic inflammation predisposes to the development of cancer. And so we think that the absorption of aspirin locally in the bowel reduces that microinflammation. But it's very debatable, and there's a lot of ongoing research in that space as to how it actually works. The next type of hereditary cancer predisposition to bowel cancer is the polyposis syndromes. So Lynch syndrome, non-polyposis, although those cancers do still start as adenomas. Moving on to talk about FAP, familial adenomatous polyposis coli. This is a condition where people develop hundreds to thousands of polyps in the bowel. Again, it's a dominant condition caused by heterozygous mutations in the APC gene. And these people start developing bowel polyps as young as 7 years old. So this is one of the few hereditary cancer syndromes that affects children. If it's left untreated, colon cancer is inevitable, and the mean age of diagnosis in untreated individuals is 39. 25% of the individuals with FAP do not have a family history of the condition. So in 25% of cases, this is a de novo genetic change, something that happened in embryogenesis that was not inherited from mom or dad. So a lack of a family history of polyps does not exclude FAP as a diagnosis for a young person with lots of polyps. We're now teasing out that there are multiple forms of FAP, again, all caused by mutations in the APC gene, but at different spots in the gene. So you can get the classical phenotype with thousands of polyps. You can get an attenuated phenotype where you have maybe 30 or 40 polyps. You can get a desmoid-only phenotype where these people develop desmoid tumors but don't have polyps. And if the mutation is sort of in the promoter at the very front end of the gene, you can get a syndrome called GAPS, which actually they get gastric cancer and very proximal polyposis of the GI tract. So what we thought was very straightforward, mutation in APC equals FAP. As we study more families, we're learning is not quite that straightforward, as is sort of the trend in everything in genetics. How do we manage these patients? So they have annual colonoscopies from about 10 to 12 years old. And endoscopies from about 25 years old based on the Spiegelman criteria, which are about family history. All of these patients will have a subtotal colectomy when the polyp burden becomes unmanageable, but the age of that will be dependent on the polyp burden, usually in the teens or early 20s. This is one of the conditions where we would test children in the family. Normally we don't do predictive testing in minors for hereditary cancer syndromes, but because there is an early onset, in this condition, we would test children, and of course that information can be used for pre-implantation genetic diagnosis. So it can be used to make reproductive decisions for these families. The other polyposis syndrome that I wanted to mention, which I don't think gets enough press, is called MAP, or mute-YH-associated polyposis. This is one of the few cancer predisposition syndromes which is recessive. So you have to have two mutations. You have to be a homozygous mutant in the MYH gene to develop polyps. So again, these people often have no family history because their parents are carriers with heterozygous mutations and no symptoms, no phenotype, but then they have a child that develops polyps. Again, people tend to develop hundreds of polyps, maybe not thousands. If untreated, bowel cancer is inevitable, and the mean age of diagnosis of cancer is a little bit older, about 45. And these people are managed in much the same way as people with FAP. All right, that was the brief. That was breast and bowel cancer genetics, but I thought I might quickly mention 2 other genetic predisposition syndromes, both very rare, but both very important to pick up. The first one is Fraumeni syndrome. This is a result of heterozygous mutations in the TP53 gene. So again, it's a dominant condition. TP53 is sort of the keeper of the genome. So it controls cell cycle. It tells cells to die, to apoptose when they have DNA damage. So without TP53, you get cells with lots of genetic alterations that just continue to proliferate and become cancers. And the cancers most commonly associated with Fraumeni are leukemias, soft tissue sarcomas, adrenocortical carcinomas, and primary brain tumors. But it's also associated with a significant risk of early onset breast cancer. And unlike BRCA1 and 2, these breast cancers are often triple positive. So ER/PR positive, HER2 positive. So a different breast cancer phenotype than BRCA1 and 2. And I know you can't probably read all of that, but those are the criteria that we use to try and pick up Fraumeni syndromes in families. So you'll be able to have a read of that when you get the slides. And the most common one we use is the one in bold, the Champray criteria, to come up with a diagnosis for these families. The risks of cancer in Fraumeni syndrome are staggering. And these are often families that have a really high burden of cancer. The lifetime risk of developing cancer for a woman is nearly 100%. And by the time she's 50, she has nearly a 90% chance of developing cancer. And that's because of the significant increase in breast cancer risk in young women. But there's also a significant increase in the risk of sarcomas, 50% by age 70. And again, sarcomas are difficult to treat cancers and often have a very poor prognosis, unlike breast and bowel cancer, which if picked up early can be treated quite well. Adrenocortical carcinoma is an exceedingly rare cancer in the general population, but is almost pathognomonic of P53. So if we see someone with adrenocortical carcinoma, we're immediately suspicious that this could be Fraumeni syndrome. This could be a P53 mutation. So that's one of those sort of red flag words. If you see adrenocortical carcinoma, that's very unlikely to have happened on its own. And again, those are often in children. This is the Toronto Protocol, which is a published screening recommendation for people with TP53 mutations. So this is how we manage them, and this is how we try and reduce their cancer risk. Now, you probably can't read the details, but it is a burdensome screening program. It involves annual whole body MRIs, annual breast MRIs for the women, endoscopies, colonoscopies. So it's a very intense program. There are concerns about the use of annual MRI with gadolinium and what we might be doing to people long term in terms of neurological deposition of the GAD and renal deposition of the GAD. So it's still early days really to manage these patients. And there is a lot of anxiety around this sort of screening for these patients. This is the overall survival data using this protocol just to demonstrate that it does make a difference in overall survival. So red is the people who had surveillance and blue is the people who didn't have surveillance. So you can see that there is an overall survival advantage to this type of surveillance program. And this was a really tricky study and there were a lot of flaws because they didn't feel it was ethical to randomize people to no surveillance given the very high risks of cancer. And so this trial was run as opt-in, opt-out. Patients got to decide. They could choose to go on the surveillance arm or choose to go on to no surveillance. And so there's obviously a lot of other factors that play into that decision: anxiety, patient diligence, regular follow-up. So people who were on the non-surveillance arm may have sort of been ostriches, put their heads in the sand, not thought about it, not get investigated when they have symptoms. So there's a lot of problems with the design of this study, but I think it's the best data we'll ever get. In In terms of what we're doing in Australia for managing these patients, the screening's obviously really complex and none of it is Medicare rebatable at this stage. So those whole body MRIs do not have a Medicare rebate. So it's a huge out-of-pocket cost for patients who want to go undergo screening. There's a clinical trial running at the Peter MacCallum right now called SMOC that is doing this this screening protocol for patients with TP53 mutations. And it's a very intensive protocol, as you can see outlined there. Last 3 slides are quite busy, and really they're just here for your reference to look at a bit later. But everybody forgets about hereditary renal cell cancer, so I wanted to sneak it in at the end. There are lots of different conditions that can cause hereditary renal cell cancer, and a proportion that can cause clear cell cancer, including BAP1 mutations, the SDHs, so the pheochromocytoma and paraganglioma predisposition syndromes, von Hippel-Lindau, TSC, tubular sclerosis, and then there's a couple conditions that can cause non-clear cell renal cell cancer, which is a much less common subtype of renal cell cancer, including Birt-Hogg-Dubé syndrome, hereditary papillary renal cancer syndrome, and hereditary leiomyomatosis and renal cell cancer syndrome. So they're all a mouthful. They're all very complex. The fascinating thing for me about renal cell cancer syndromes is that most of them have a cutaneous set of symptoms. So most of them have a skin phenotype. So you can often pick up these inherited syndromes without even thinking about someone's kidneys and long before they develop kidney cancer. So I've just put up a few pictures so that if you see something like this in your clinic, it might flag that maybe I need to investigate this a bit more. So the first 2 pictures here are of patients who have tubular sclerosis complex, TSC. These are the facial angiofibromas that they get, little red facial lesions, usually sort of centered around the nose and the upper cheeks. And this is a picture of an ungual fibroma, so a fibroma under the fingernail. And those are both very classic of TSC. And this is a patient who has a BAP1 mutation. They tend to develop these skin lesions, which are conveniently called BAPomas. They used to be called atypical Spitz tumors in the sort of old nomenclature. And they can look very benign, or they can look a bit uglier, a bit more aggressive. And these are usually very young patients, older children, teenagers. These skin lesions here are cutaneous leiomyomas. So they're benign tumors arising from the muscle in the hair follicle, the smooth muscle in the hair follicle. They are usually sort of red to purplish, and they're palpable lumps in the skin. And the classic description of these from the patient is that they hurt when I'm cold. Because when that patient gets goosebumps and that muscle tries to contract, it squeezes the tumor in the hair follicle. And so lumps that hurt in the cold are very suspicious of cutaneous leiomyomas. And finally, down here at the bottom, most subtly, I'm not sure how well it projects, you can see these little white skin papules. They almost look a bit waxy under the skin. Classically, on the face, around the ears, and on the neck or upper chest. And these are trichodiscomas or tripoepitheliomas, and they're associated with Birt-Hogg-Dubé syndrome. So they're much more subtle. They can be quite tricky to pick up. But I guess if you see patients with something that you're suspicious about, either biopsy it or refer them off to the dermatologist for a biopsy. And anyone who has confirmed to have any of these cutaneous lesions, we want to see in the Familial Cancer Center. So in terms of renal cell cancers, anyone who's diagnosed with kidney cancer under the age of 40, anyone who has bilateral kidney cancers, anyone who has an unusual type, so not clear cell, but anyone who has an unusual phenotype of kidney cancer, or anyone who has skin cancer in combination with funny skin nodules or tumors elsewhere, we want to see. And I think that's it. So my take-home messages, cancer is common. Most cancer is not caused by a single gene, but we need to watch out for patterns of hereditary cancer which could indicate a single gene. So young people developing cancer, people with very rare subtypes of cancer, or multiple cancers in the same individual, and people who have a strong family history of clusters of the same cancer. And can we improve these people's management and these people's survival? We have good data now that we can. Screening works if we can pick these things up early. Chemoprophylaxis or risk-reducing medications work. and there are surgical risk reduction strategies for some of these people. So if we pick these people up early and we get them onto the appropriate screening programs, we can reduce the cancer burden and mortality in this population. And if in doubt, and if you have any questions, I recommend starting here. And Mike has already put this address, website address in his slide as well. This is eviq.org. It's the Cancer Council, or Cancer Institute, sorry, of New South Wales website. So it's Australian, and it's all evidence-based, and it's all peer-reviewed. There's a tab over here when you go to their homepage for cancer genetics. And if you click on that, it has very good resources about who we would test, what we would test, how we would manage those patients. It's also a great resource if you have patients who have cancer in the hematology or medical oncology or patients and carers tabs. There's lots of resources there about chemotherapy protocols, managing chemotherapy side effects, carers support for cancer patients. So as an oncologist and a cancer geneticist, this is my homepage on all of my computers, and it's always where I start, and it's where I'd recommend you start if you have any questions as well. All right, that's the end of my presentation. I'm happy to take questions, or I'll hang around for a cup of tea if people want to speak to me at the break as well.
Regarding the prevent, I think it was by both of you. Prevent one.
I prevent?
I prevent.
Yeah.
I mean, do we have to register just go in there?
Yeah, so there was a clinical rollout trial that was being done with a number of GP practices where they had them register because they were seeing if it would work, if it was usable and if it was applicable. But I think that's over, or it's recruited anyways fully. So now you don't have to register. And patients, we actually recommend that you just give the address to your patients. And I brought some cards along that you can take home, and that you get the patients to do that in their own time. Because it does take about 15 or 20 minutes for them to put all of that history in. And then they can print that out and bring that to you. This was my risk. And you can talk through the management. Right. Excellent.
I'm at breakfast and morning tea.